You're going to introduce Joe?
He needs no introduction.
He needs no.
Thank you all very much for coming tonight. At our clinic, we've done over 800 cases with PRP and shockwave therapy over the last 5 years. And what I'm going to show you now is some of the best cases to get you all interested in the clinical aspect of this. And what I really like about specialty med is really a collaborativization of everyone here and others who could not make it, sharing their data, their expertise. I think what Lisa's going to tell you next is just, I couldn't stop thinking about it because she was talking to me before this, and I think it's really going to help us with the standardization of how we practice medicine. So I'm going to talk about platelet-rich plasma and shockwave therapy, the most advanced and promising treatment options for male and female sexual dysfunction. This is from one center, and I think that when we have this talk next year, it'll be completely different. Because it is, I think as Lisa said earlier when she gave the introduction, it is evolving. And when I started to learn platelet-rich plasma, completely different than how I utilize it now.
And that was only, a handful of years ago, right?
So what do we have for erectile dysfunction? We have nutrition modification and exercise, still the hallmark of getting the best out of the patient. Hormonal balance, we always want to make sure that the patient's testosterone level is fine if we're dealing with a man. Vacuum erection devices have been around since the late 70s, and early on we used to use them as treatment, but now what I do in my practice is they're exercise tools. They help get the blood in. They help soften up the plaque after patients have had platelet-rich plasma. PDE5 inhibitors, they've been around since March 28th, 1998. They're excellent. But what we have found are that the patient who responds to the Viagra, Levitra, Stendra, Cialis, after a while, they become non-responders. But what happens is because they did nothing to modify their nutrition or their exercise, and if they had diabetes, hypertension, heart disease, it just continues. You take a pill and you mask it. And then those patients who are the non-responders have been the ones that have really responded to PRP. Penile injections, so there's vasoactive drugs we use, Trimex and Prostadil, which is a prostaglandin E1. These we teach the patients how to get an erection. And then we have platelet-rich plasma, shockwave therapy, and penile prosthesis. So when I'm training a clinician, I want to make sure that that clinician doesn't stop here, because we know, at least from my experience in talking to other providers, we're only getting to about 80 to 85% of the patients who come to our office. So that means 15 to 20% are not being cured. So what I try to do is hook them up with a urologist in their city who can at least provide them a penile implant if they so desire. And I think that's very important. You don't want to leave your patients hanging. You want to try to do it. And I've been practicing medicine for 30 plus years, and I've been performing penile implants. And since I've started using platelet-rich plasma and shockwave therapy, I've actually seen an increase in my implant practice grow, because I'm seeing more and more patients. So For platelet-rich plasma, it's helping with erectile dysfunction. Peyronie's disease is a plaque-like formation which can or cannot cause a curvature, premature ejaculation, penile implant issues, decreased sensitivity, a cold penis following an implant, pelvic pain, hair regrowth, overactive bladder, stress urinary incontinence, female sexual dysfunction, vaginal atrophy, and dyspareunia in women of all ages. So this is the IIEF score, or the Index of International Erectile Function. This is one of the objective criteria that I use in my practice. History, physical examination, laboratory data. This is anywhere you can get a score from 0 to 30. 0 to 7 is severe. 8 to 16 is moderate. 16 to 21, mild. Over 22, usually within normal limits. So this was a patient, 44 years old. He came to see me from a town of about, can I go backwards? Okay. He came to see me because he said he had a curvature of his penis, but everything else was okay. So when I examined him and I talked to him, I saw that his IIEF score was 15, well within the erectile dysfunction range. So he did not want to have anything else done other than shockwave therapy. I tell them all the different modalities we have: platelet-rich plasma, shockwave therapy, surgical intervention. When we concluded with the 12-week follow-up, his IIEF score jumped to 29. This was the plaque causing a 20% downward curvature of his penis distally. And 12 weeks post-op, it's gone. He also had some linear calcifications, pinpoint. Those are also gone. Now, again, this is the best case scenario. These are great pictures. It doesn't happen all the time. So this is a 61-year-old gentleman. He started with an IEF score of 18. He had pre-treatment. He had shockwave therapy, and he also had erectile dysfunction. He had low testosterone. He was on antidepressants. And here we see a duplex ultrasound. This is part of my practice that I want to see objective criteria. I want to know exactly what's going on with the arterial velocity, the venous velocity. I want to look at the architecture. So that is part of our routine to get penile duplex ultrasonography. So we hear this patient went from 55 centimeters per second arterial upflow, but he had a venous leak that was at 10 centimeters per second. Post shockwave therapy, again, he went up to 84, and there was almost no venous leak whatsoever. So after, this patient also had platelet-rich plasma, and again you can see that his numbers jumped up, his arterial velocity jumps up. So if you can think about what happens with erectile function, you have the arteries pouring blood in, and then what happens, the patient will typically tell you, I get an erection, I change position, or I lose it. And that's because the venous leak is bigger than the arterial inflow. So, excuse me, take a drink. Are there any questions yet?
Yeah, how many shockwave therapies does this patient have?
This patient had 6 shockwave treatments. He also had 2 platelet-rich plasma. This was in the time period before I used my new protocol. Patient C started out with an IE of 20, mild dysfunction, hypogonadism. You know, if you look at the literature, probably about 20% of the patients who come to your office have low testosterone. In my particular practice, I see a great number of them, and mine are over 50%. This person had shockwave therapy, platelet-rich plasma. He increased from an IE of score of 20 to 27. This is a mistake. It was only 27. His venous leak decreased by 50%. And I think I can show you here. So his velocity was at 53 pre, and venous leak was at 12, and it went from 43 to 11. That was on the left side. And then post-treatment, we can see that the velocity, arterial velocity changed somewhat, but the venous leak decreased enough to get the patient a good erection. So what is this is telling me? This patient probably, ideally, will come back in about 6 months and probably have another series of treatment. Ideally, probably another platelet-rich plasma and shockwave treatment series. He's responded very nicely to nutrition. He's also lost 35 pounds during his treatment. So this patient had ED from a penile curvature. He had radiation therapy for a pelvic sarcoma, which after the radiation treatment, he noticed the erectile dysfunction. So he started off with an IE of score of 12. His systemic velocities were 48 and 47 respectively, with the diastolic being at 20 to 15. He underwent platelet-rich plasma ×2 and shockwave series. This particular patient had 8 treatments. So it is now my standard that when I perform platelet-rich plasma, I start off with shockwave therapy, and then they get the platelet-rich plasma, and then the following week they get 2 treatments of shockwave therapy for the next two treatments every week for the next 3 weeks. I wait 4 weeks, and then I administer the second platelet-rich plasma along with the shockwave treatment. And that's my particular protocol for difficult patients. But this patient responded amazingly well from 12 to 27. So much so you could see how great the venous leak was. This particular patient was a 52-year-old woman who was an avid runner. She called me up because she had been online, and this was at the beginning when I first started to use platelet-rich plasma. So she came to see me, and in the midst of getting her questionnaire, we asked a few questions and said, you know, I also haven't had an orgasm in 4 years. That was wrong. It was only 4 years, not 16. So we did balance her hormones. She did get a platelet-rich plasma O-shot. And 2 weeks afterwards, she texted me that, well, the first week she texted me, she said no results. Second week, she texted me, I just ran my race, won my division, and I'm perfectly dry. But no orgasm. The next week she texted me, okay, not 1, but 3. And this particular patient is over 4 years old, and she still continues to talk to me periodically and get the good result without any additional treatment, except for periodically she does come in for pellet therapy. Yes?
This particular patient, how much of her improvement on orgasm component would you attribute to her hormone balancing?
You know, I think it's really hard to differentiate that. I think that there's no question. We know that, you know, I can attribute the platelet-rich plasma solely to the treatment of her stress urinary incontinence. But, you know, I think I have to say that, you know, balancing her hormone and increasing her testosterone and estrogen probably did help her, at least in a partial way.
How is the shockwave therapy administered in women?
Very carefully.
Right.
So, we just started doing this about 4 months ago, and we have we're anywhere from 5,000 to 10,000 shocks are administered in the area of the clitoris, behind the clitoris, down the labia major, the labia minora, and then inside the vagina in the level of the rugae, in the area of the so-called G-spot, where 2,000 shocks are administered. Yes?
When you use the male for penile, I'm sure that it's being treated with some sort of like medication to get erectile, and you scan the Doppler with the penis being erectile?
Yes, we use a vasoactive drug, either Trimix, which is papaverine, phentolamine, and prostaglandin E1, or we just use prostaglandin E1.
And the same question, do you use ultrasound as well for the O shot, or all that? Do you scan with the ultrasound?
No, we haven't done that yet. Yes, Eric?
So can you, if you recall, elaborate on, it looks like there's a 7-month hiatus between the first T-shot or O-shot rather, and then when you did follow O-shot, shockwave, why, I guess, background?
So I want to say this slide was a mistake. Okay, this was a different patient. She really only had one O-shot, and that's all she had. She's probably had pellets probably 12 different times, but she only had one O-shot. So that was a mistake on my part. And also, she did not have any shockwave therapy at all. So, my fault on that.
Assuming if needed, what's the frequency of the PRP shot, but then injections as far as the patient has one today, how soon to the next one, assuming needed? What's the urology?
Well, we like to say that there's probably 12 weeks for the platelet-rich plasma to reach its full potential of regeneration and rejuvenation, and that's generally what we do. The only time that varies is when I have a large Peyronie's plaque, and then I probably will use anywhere from 2 to 6 platelet-rich plasma treatments, and lately I've been incorporating shockwave therapy in all of that. I think for the smaller one that the first person had, I mean, complete disappearance of the plaque was great. But when we have these large anterior plaques, I also have to tell the patient that there is a medication out on the market called Xiaflex, which is FDA approved, which in my hands, it does not give very good results. I don't know if you've had any result with it, Eric, but around 50% success rate. Very expensive drug, very time consuming. Well, since this and it will only work on the calcified plaque, but since this patient already had erectile dysfunction, he opted for platelet-rich plasma therapy. Prior to 5 years ago, if I had a patient who came in with erectile dysfunction and Peyronie's disease, I'd offer them a penile implant because there was no other treatment. If you're going to fix the plaque, you still are left with erectile dysfunction. So you might as well straighten out the penis and place a 3-piece inflatable implant in. Yep.
This patient with stress incontinence, do you inject anterior vaginal wall and periurethral?
Correct. Yes?
The volume of the injections, the P shot, and how many sites?
So the sites are, if the patient does not have any Peyronie's, and it's just, then if I'm going to take and say the penis is this big, a tourniquet is going to be placed at the proximal portion, and I'm going to put 4 cc's and then step up until I get 1 cc left, and that 1 cc will go on the corona of the glands for sensitivity. What are you shutting me off? Oh, sorry. Oh, okay. I can't talk. But anyway, you can ask me questions about that. But the important thing to know is that we only inject on one side. Suffice it to say, unless it's a large plaque, and then I will hit the plaque at different angles. Any other non-protocol questions?
Do you combine these modalities like Xiaflex and
I have on one occasion when the Xiaflex did not work, and then I went to PRP.
at what point do you decide that this is not working, let me switch off? Is there
With the Xiaflex, probably it was greater than 12 weeks. It might have been 4 months. And very expensive. Not all insurance companies pay for it. It's around $40,000. Any other questions before I get?
After you draw the stem cells, how long do you have till they?
The platelets, you mean? The platelets?
Platelets, yeah.
You know, we have a very efficient system at our, so only one patient is treated at a time, even though we may do 5 or 7 patients in a day. So from the moment it's taken from the patient and brought back is probably between 30 and 40 minutes. So as I was telling Dr. Vuich that I wish she would have gone after Dr. Evers because, and I just met Lisa, and what she has to say is super exciting, and it gets us all thinking about the standardization because, you know, I've had patients come from all over. I'm in a little town, Peoria, Illinois. But patients tell me their horror stories of the type of PRP that they received. And it wasn't worth a damn, and it didn't do anything for them. And so I think this is one way that we're getting to a standardization. So
Last question, how many cc's of the calcium gluconate or carbonate do you add to the PRP?
generally 0.5, is that okay to say? Okay. I'm going to leave. Lisa?
Give it up.
Thank you.
So you're giving up the mic before you get in more trouble, basically. Yeah.